Well, good afternoon, everyone. And thank you for joining us at this industry-sponsored symposium. We're going to let people continue to get lunch, so please stay in line, get your lunch, and sit down. You can kind of make noise. It's okay. We just want to get started on time because we have a very packed agenda to take us through. So I'm excited to see so many people here. Welcome to Korea. It's my first time in Korea, and I'm having a wonderful IGCS, and I hope everyone is as well. This is industry-sponsored symposium entitled Target Practice Zeroing In and Eliminating Ovarian Cancer, a course review and understanding the ADC opportunities that exist in ovarian cancer. I'm Dr. Kathleen Moore, Deputy Director of the Stevenson Cancer Center, and I will be moderating today. So we will get started. Let me just advance. Welcome. I'd like to introduce our expert panel. Sitting beside me, Dr. Isabelle Ray-Coukard, Dr. Linda Duska and Dr. Roisin O'Carroll will be our faculty today. So my very esteemed colleagues, I thank them for participating. These are our disclosures, and I'll leave those up for a moment. And this is our agenda. So it's very packed. And these are all, I have to give credit to my faculty. These are sort of new content, sort of a new way of organizing the development of antibody-drug conjugates. So I'm hopeful that you'll learn a lot today and participate at the time of question and answer. We have microphones throughout the room, and we really want you standing up asking questions. That makes this a lot more fun for everyone. But this is what we're going to be going through today. We're going to start in a moment with Dr. Ray-Coukard taking us through the current data in antibody-drug conjugates in ovarian cancer. This will be followed by Dr. Linda Duska, who's really going to take us through, we know the efficacy, but what's the price? What's the cost? What's the quality of life? Really germane given the presidential session today. What do our patients have to go through in order to get the benefit of antibody-drug conjugates? After those two talks, we'll take a break and have some questions and answers for about 10 minutes. And then we're really going to look to the future with Dr. O'Carroll on sort of how do we continue the next generation of antibody-drug conjugate development and move more and more of these agents into treatment. So a lot. And then we'll have more question and answer. So without further ado, I'm going to turn the podium over to Dr. Ray-Coukard, who's going to take us through ADC opportunities in ovarian cancer. Dr. Ray-Coukard, thank you. And thank you for coming.
Thank you so much, Kathy. Hello, everyone. My name is Isabelle Ray-Coukard. I'm a medical oncologist working in Lyon, France. It's my great pleasure to be there today to speak about this important topic. Before to that, I would like to thank the GOG partner, the EGCS, but also our sponsor who give us the opportunity to have a faculty with 4 women. It's not so usual, so I'm very happy to thank you all the organizers to give this opportunity. So now we will move in the detail about EDC and what is the opportunity for our patients with ovarian cancer. Before to move in the detail, we need to come back to the reality and why we decide to build EDC by the past. In fact, EDC were really developed to limit the systemic toxicity, but also to improve the therapeutic index of our cytotoxic agent. Why? Because we use cytotoxic agents since decades to treat our cancer patients. And when we speak about therapeutic index, we mean that maximal tolerated dose balanced to minimal efficient dose. And looking to what we see with EDC, we have the opportunity to improve the efficacy and to reduce the toxicity, reducing the toxicity of the payload, but also with limiting the exposure of healthy tissue to cytotoxic drug. How does that work? EDC induces cancer death via the release of the payload. The antibody binds the target antigen at the surface of the cancer cell. There is internalization and by endocytosis. And then, looking to endolysosomal degradation, we have the possibility to see the payload moving in the cytoplasm, acting with the microtubule or DNA, and resulting in an apoptosis cell death. So when you think to antibody, you need to look to 3 important topics. What is the tumor antigen, who will be the specificity of your antibody? What is the payload, who will be at the end the killer of your tumor cell? And what what could be the linker and the activity to help the payload to be particularly efficient. Effectively, the linker is really designed to ensure that the ADC will be highly stable in the circulation, but yet able to release the payload in the tumor cell. And so we have right now cleavable linker and non-cleavable linker. Looking to the non-cleavable linker, it's really more stable in the circulation, but not able to diffuse to the neighboring cancer cell. And so it will be safe, but less active probably if we look to cleavable linker. We finally use the property of the tumor cell to release the cytotoxic payload, but potentially to have premature payload release, and so able to have a little bit more toxicity. Considering the payload in terms of solid tumor, we use frequently two classes of anti-tumor drugs, the microtubule inhibitor, who are particularly efficient for proliferating cells, and the DNA damage agent, who could be efficient independently of the cell cycle. In terms of example, we have the sacituzumab govitecan and trastuzumab, who are using DNA damage agents, and mirvetuximab, soravtansine, and tisotumab vedotin, who are using microtubule. An important topic is the bystander effect. It will be developed later on, but it is important to remember that it is particularly interesting when we are speaking about solid tumor, and more particularly tumor with heterogeneous antigen expression. Because in this case, the payload can diffuse from the target cell into the neighboring cell and able to induce what we say a cell death. It could be something really interesting to improve our therapeutic index. However, if the payload diffuses into the healthy tissue or bloodstream, it can lead to off-target toxicity. This is something that we need to take into consideration. The current approved EDC payload, as you can see on the slide, were represented for 50% by tubulin binder, as I mentioned before, but also DNA binder or DNA alkylator, particularly used for hematological malignancy. And more recently, we see the topoisomerase 1 coming more and more frequently. But in addition to cytotoxic drug, immune-stimulating EDC with toll-like receptor or STING agonist are in early phase right now and clinical investigation. And this new payload could be particularly interesting for specific cancer, including immune cell microenvironment. So it will be something important for the future. If we want to summarize the currently approved ADC in the United States. We speak a lot with my colleague before. We have 13 FDA-approved ADC, but the world is working very quickly. As you can see, the majority of these EDC include IgG1, more than IgG4, several different targets. Interestingly, most of them use cleavable linker with different payload, including DNA targeting, tubulin, topoisomerase. There is also important thing to remember is the DAR, drug-to-antibody ratio. That can be something important to explain efficacy and sometimes toxicity. But also, I remember you that the bystander effect is something important to remember for your antibody when you look at the activity of an ADC. And finally, the immunogenic cell death. This is something important. We see that auristatin could improve the immunogenic cell death, and it is something that we will more and more develop in the future. Considering gynae cancer, right now we have two ADC approved. The mirvetuximab soravtansine for FR-alpha ovarian cancer and tisotumab vedotin. But there is also several other targets of interest already mentioned in the literature, B7H4, CDH6, FR-alpha, HER2, mesothelin, tissue factor, and TROP2, where we see that the majority of these targets have overexpressed in ovarian cancer or in gynae cancer in general. And the good news is that we have already data and drug in the clinical development who look particularly to these targets for ovarian cancer. We will move in the detail. But starting with the first one, mirvetuximab soravtansine is the first FR-alpha targeted EDC approved in the treatment of platinum-resistant ovarian cancer after the accelerated approval in November 2022 based on the SORAYA trial. We include platinum-resistant ovarian cancer who already received BEV prior to be included, no more than 3 lines of treatment, and an FR-alpha positive high expression in this trial. The investigator report a response rate of 31.7% using this monotherapy with a duration of response of close to 7 months with the treatment and a safety profile acceptable in this population of patients. These results were immediately confirmed by the large phase 3 MIRASOL trial, a GOG and GOT collaboration, exploring the soravtansine versus chemotherapy in FR-alpha high population, platinum-resistant ovarian cancer. The standard of care considered in this trial were paclitaxel, weekly paclitaxel, PLD, topotecan. The population is the same population than in SORAYA. Also in this phase 3, the bevacizumab is not systematically mandatory. It's allowed, but not mandatory. The primary endpoint is PFS, and key secondary endpoints include overall survival. The results were presented by Cathy Moore this year at ASCO, and we have seen that the hazard ratio in favor of mirvetuximab is 0.65, with a median PFS in the chemotherapy arm close to 4 months and 5.6 months for the mirvetuximab arm. What we see is interesting is that we see a very quick separation of the curve in favor of a rapid efficacy of the antibody compared to chemotherapy. The results were supported by the secondary endpoint overall survival with another ratio of 0.67. That means a 33% reduction of risk of death using the mirvetuximab compared to chemotherapy. The median overall survival in the chemotherapy arm is a little bit more than 1 year, as we anticipate, and in the MIRV arm is more than 16 months. They also report the activity in terms of response rate, and you can see on the waterfall plot that we have 80% of patients with tumor reduction using the mirvetuximab versus only 55% with chemotherapy. In post-hoc exploratory analysis, also there is some bias, we have to be careful. We see interesting data considering the patient who already received PARP. We have seen with SOLO2 and now more recently with PAOLA-1, how the patients who progress during PARP inhibitor are particularly less sensitive to chemotherapy. So it's interesting to see that in such setting, we have some drug, as mirvetuximab, able to improve PFS and overall survival. Considering the safety profile, I don't want to move too much in the detail. It will be detailed later. We see that considering grade 3 and more treatment-related adverse events, serious adverse events, and discontinuation rate, all of these factors are in favor of mirvetuximab compared to chemotherapy. How we can do more, how we can do better, how we can move forward. It is exactly the question of the Forward 2 phase 1/2 study, who explored the combination of this drug, mirvetuximab soravtansine, plus bevacizumab. You remember that in the particular setting of resistant ovarian cancer population, bevacizumab plus chemotherapy bring a huge response rate, PFS, and overall survival compared to other exploratory data. And we see with this importance how BEV can be in combination with some drug. And so exploring the combination with MIRV seems to be particularly interesting. Also, as you can see on the slide, not only in the FR-alpha high expression population, but also for ovarian cancer patients with FR-alpha medium or low expression. And what we can see in the recent publication in terms of response rate, 44% in the overall population. We see also that the activity looking to the FR-alpha expression is very good. Also, we see a higher activity for the FR-alpha high. We see more than 30% of response rate in the medium, but also in the low expression of FR-alpha. And when we look to the subgroup, we don't see any difference looking to the platinum-free interval. Also, we see a better response rate for patients who never received BEV before. And also, we see a response rate of 63% for patients who receive only one prior line of therapy. but 41 and 32 for patients who receive more lines of treatment. And at the end, when you look at all the response rate, we see more than 30% of response rate in all the subgroups, that it is also something interesting. In terms of safety profile, it was relatively good. Most of the treatment-related adverse events were low grade. 48% of the patients experienced grade 3 and more, and in general is due to hypertension. We have 30% of discontinuation of MIRV and 37 discontinuation for bevacizumab. And at the end, there is only one death related to study treatment. It was an intestinal perforation, possibly related to bevacizumab. Is there other promising FR-alpha ADC right now? Yes. We can speak about the Luvelta, who report the result this year at ASCO and ESMO. This compound uses a microtubule cytotoxic payload. The DAR is 4, the linker is cleavable, and in the dose expansion study, including platinum-resistant ovarian cancer, evaluating 2 doses, they report a response rate of 31.7%, and we move to 37.5% in the population with a high expression of FR-alpha. The safety profile is completely different to MIRV. We see more neutropenia and peripheral neutropathy. The dose reduction is quite high, 61%, but at the end, the dose reduction is very low, less than 7%. And due to these good results, the phase 3 will starting soon. There is another one, the MORAb 202. The payload is a ribulin, DAR4, linker is also a cleavable linker. And again, in the phase 1 dose expansion study, including high-grade ovarian cancer, we see nice results in terms of response rate and duration of response, 25% in the cohort of low dose and 52% in the higher dose. In terms of treatment-related adverse events, we have to say that most of them were linked to the interstitial lung disease or pneumonitis. We see also some nausea, pyrexia. The result seems good, and right now we have a randomized phase 2 exploring different dosage before to move to the phase 3. There is also 2 other promising FR-alpha ADC to be mentioned. The first one is the PRO 1184. The novelty of this compound is the linker, a little bit more hydrophile, and also the payload who include the topoisomerase 1. The results in the preclinical data are very good, and we are right now in the expansion dose cohort, including gynae cancer. The other one is a new coming from Immunogen, the EMNG 151, which is a particular mechanism to bind the tumor cell, including 2 independent epitopes for FR-alpha. I think that it could be interesting to explore this pathway. And effectively, the preclinical model, as you can see on ovarian cancer, but also on endometrial carcinoma, are very good. And again, the phase 1 is ongoing with expansion cohort dedicated to gynae cancer. Is there other target of interest? Yes, we mentioned before the CDH6, and we have now this new compound, raludotatug deruxtecan, coming from Daiichi. The payload is a topoisomerase 1, DAR8, and Katimur again report the nice result at the ESMO meeting this year, where we have seen in the expansion cohort, including 60 ovarian cancer, platinum resistant, a confirmed objective response rate of 53% and a disease control rate of 98%. The median time to response was very short, 6 weeks. The median duration of response is more than 11 months, and the median PFS is close to 8 months. In terms of safety, we have essentially digestive, nausea, vomiting, adverse event, and hematological toxicity. And looking to these results, the phase 3 is coming soon. There is also HER2, who could be an interesting target in ovarian cancer, and we have the trastuzumab deruxtecan, already well explored in breast cancer. And this year, the Destiny pan-tumor report at ASCO and ESMO very nice results using this compound, using a topoisomerase inhibitor as a payload, DAR8. And we see in ovarian cancer expressing HER2 45% of response rate in the ITT population, moving to 63% for HER2 3+ and 36% for HER2 2+, with a median duration of response, again, of more than 11 months. So you have seen that we have activity of ADC in ovarian cancer, we can say yes, we have already an approved EDC available for our patient. The question will be how to improve the therapeutic index, what could be the best target, how to move if we have several EDC, and much more importantly, what could be the price for the patient to have such activity. But this answer will be addressed by my colleagues. Thank you so much for your attention.
That was amazing and right on time, because it's all women run. We stay on time. So you brought up kind of the transition, which is you've presented a number of agents with incredible early efficacy, and I think we need to hear about the cost of sort of what that efficacy, what price does it come at? So Dr. Duska is going to take us through some of the considerations for quality of life and patient-reported outcomes with antibody-drug conjugates. Thank you, Dr. Duska.
Thank you for the perfect segue. It was very much appreciated, and the invitation to speak to you all today. It's really an honor to be here. So we've heard a lot at this meeting at ESMO and at ASCO about some really wonderful new options that we have for our patients with ovarian cancer. We've really made some significant strides in the platinum-resistant space. We have heard less about the effect on patient-reported outcomes and quality of life. And this is primarily because of the way we design our studies. So PFS or OS are primary endpoints, and health-related quality of life is rarely a primary endpoint in most of these trials, although it's usually included as a secondary endpoint. But that said, it may be the single outcome that's most reflective of patient priorities when living with a health condition, and so it's really important for us not only to study this, but also to understand it well. And in order to have a conversation with our patients, not just about the outcome from the drug, but also how this drug will affect their quality of life, is really important in helping them to make decisions into proceeding in shared decision-making. So I'm really glad to have the opportunity to talk about this particular topic today. And maybe I can figure out how to advance the slides. There we go. So relying on data regarding drug toxicity is important, but not sufficient to assess the effect of a novel treatment on a patient's quality of life. That said, we're going to begin with a discussion about toxicity and then segue into talking more specifically about quality of life. So this slide shows the potential mechanisms of toxicity associated with ADCs. And as has already been said, the ADC is designed to target the payload to the cancer cell with antigen on the cancer cell. This is called on-target, on-tumor toxicity. That's what's supposed to happen. But we also know that there can be other mechanisms of toxicity associated with ADCs, and in general, primarily these toxicities are related to the payload, although the toxicities can be related to any part of the antibody-drug conjugate. So this cartoon that you see on the left kind of takes you through the different modalities of toxicities that we see. In number one, all the way over on your left, is target-independent toxicity. This occurs when the ADC or its payload is taken up into a non-malignant cell, either by nonspecific endocytosis, macro or micropinocytosis, or binding to Fc receptors. The second type of toxicity that we see is on-target, off-tumor toxicity. So in other words, the target antigen may be expressed on normal cells, so the ADC is taken to the normal cell, which is not ideal, and then contributes to target antigen-dependent uptake in the normal cell. A great example of this is the eye toxicity that we see in tisotumab vedotin, because we know that tissue factor is expressed in the eye. So that's on-target, off-tumor toxicity. And finally, it's already been alluded to this idea of the bystander effect, which is off-target, off-tissue toxicity, and happens when the membrane-permeable drug payloads diffuse from the target cell into the neighboring cells. This can be good if the neighboring cells are the tumor microenvironment, because we can negatively affect the tumor microenvironment and therefore the tumor, but it can also be detrimental if normal cells are affected. This list is not a complete list, but it's a list of common toxicities observed with selected approved ADCs in general. So this is not specific to any particular ADC. I already told you the majority of the ADC toxicity is caused by the payload, so it's not surprising that a lot of these side effects are hematologic. There was a really nice meta-analysis published in 2022 that showed that the overall incidence of treatment-related adverse events of all grades is a little over 90% for ADCs, and it's a little less than 50% for high-grade AEs. The most common that we see in this class as a whole are hemorrhage, blurred vision, nausea, and peripheral neuropathy. Although I will draw your attention to the fact that certain ADCs can also cause unique side effects, such as pneumonitis and cardiotoxicity. So it's important when you're using a particular ADC to be aware of its unique side effects. It's also notable that the toxicities of ADCs vary significantly from the toxicities that we're used to seeing with traditional chemotherapy. And I hope to convince you of that in the next couple of slides. So we've talked about the two ADCs that we have approved in gynecologic cancer, tisotumab vedotin and MIRV. The differentiated safety profiles for both of these are shown on this slide with tisotumab vedotin on your left, and I'll start with this one. Again, as I said, this is similar to the meta-analysis that I showed you earlier. The rate of all AEs is a little over 90%. When you look at grade 3 and higher AEs, it's 28%. And if you look across the graph, you'll note that the majority of AEs seen with this drug are not similar, sort of similar with some overlaps, but not similar to what we see with chemotherapy. Similarly, in the box on the right, you'll recognize this slide because it comes from Dr. Moore, and she showed us these data, I think, yesterday or the day before. I'm starting to get my days mixed up. Where you can look at the hematologic and GI toxicities of mirvetuximab compared with chemotherapy. Now, I'm going to come back to this, but what's really nice in the tisotumab vedotin data that I'm showing you here, which is from study 204, we're only looking at the toxicities from the one drug. In the box on the right, we can compare the toxicities of the ADC to the toxicities of the investigator's choice chemotherapy, which is really nice. And when we look at quality of life comparisons, it's nice to be able to compare the experimental agent to chemotherapy. The MIRV data is in the red or pink, and the chemotherapy data is in the blue. And you'll note from a hematologic standpoint, the MIRV, while it does cause hematologic toxicity, is significantly lower with respect to neutropenia and anemia than what we're used to seeing with chemotherapy. That said, we all know, those of us that have used these drugs, that there are unique toxicities observed with these approved ADCs. And let's look at the data on tisotumab vedotin first. Here, the unique toxicities that we see are ocular, bleeding, and peripheral neuropathy. Again, the majority of these are grade 1 or 2, and the minority are grade 3, shown in black. What's interesting is if you look at the box on the bottom, the time to onset for these side effects is relatively quick, usually within the first 2 cycles. The majority are completely resolved, 86% for ocular, 90% for bleeding, and the time to resolution is very fast. So while we do need to be sure that we inform our patients about these side effects, at least in my practice, my patients find it very reassuring that once they stop the drug that these side effects will resolve. We see similar ocular side effects with mirvetuximab, as you'll see on the right-hand side. What's interesting there is that this is likely not an on-target toxicity because as far as we know, folate receptor alpha is not expressed in the eye. So most likely this toxicity is caused by a differing mechanism. So most of you know that ocular toxicity is included in the black box warning for patients treated with tisotumab vedotin. And again, this is an on-target, off-tumor side effect. In the 204 trial, the incidence of any grade ocular toxicity was 54%, so it was quite high. Fortunately, the rate of grade 3 toxicity is very low, and the majority of these are ulcerative keratitis. Not very many patients had to discontinue treatment due to ocular AEs, only 5%. 20% required dose reductions or dose interruptions, and again, there were very few grade 3 AEs. There are well-published and documented mitigation strategies for both tisotumab vedotin and MIRV. The mitigation strategy for tisotumab vedotin is shown here. There is a little bit of a time toxicity here, and we're going to talk about time toxicity in a minute because of the very frequent eye exams that are required with tisotumab vedotin. You need to have an eye exam at baseline and then before every cycle. And then there are eye drops and eye masks, and then eye drops that need to be used afterwards. Additionally, contact lens use needs to be avoided while on this drug, and for me personally, that would be a huge problem. So it depends on the individual patient how much that individual is willing to tolerate this sort of eye toxicity. Mitigation strategies shown here. And here in the far right, you can see that when the mitigation strategies are utilized, there's a significant decrease in all eye toxicities in the top, as well as conjunctivitis on the bottom. So mitigation strategies can be very useful, as well as, of course, reassurance to the patient that these side effects will resolve relatively quickly once the medication is stopped. So let's move on briefly to let's move on to health-related quality of life in oncology. And health-related quality of life is really a multi-dimensional concept. It is not just physical health or ECOG performance status, but it involves all aspects of life in the same way that we think about palliative care as offering and focusing on all aspects of an individual's life. Health-related quality of life combines physical, psychological, and social well-being with patient satisfaction in disease control and functioning, and includes all of the aspects of life that you see here. Dr. Moore calls this a flower, which I didn't see until she said that, but I like that analogy. There are multiple aspects that can diminish health-related quality of life, and in particular, symptom burden and progressive symptoms can be very significant. And it's thought, in fact, and it might not surprise you, that symptom burden is one of the primary drivers of diminished quality of life in ovarian cancer. So, in other words, if we have a successful treatment that allows us to decrease the disease and thereby the symptom burden, that will then result in an improvement in health-related quality of life. I want to draw your attention to a couple of other factors that diminish quality of life here, including financial impact of disease and days off of work, hospitalization, as well as poor clinician knowledge base and poor communication. It's critical that we are able to describe the benefits as well as the toxicities of these treatments well to our patients. Setting expectations is really important, as you all know. Shown on the right are the factors that augment quality of life, including good clinician communication, as well as management of medication side effects. Both disease and treatment can negatively affect quality of life. Said another way, if the disease improves as a result of the treatment, this will positively affect. So it's really important to look at both things, the change in PFS and OS, as well as the effect on an individual's quality of life, because they're very connected to each other. Factors that affect patients in decision-making include physical toxicity, and we've talked about this, as well as financial toxicity and time toxicity. So all of these things are taken into account by an individual when making a treatment decision. What are the PROs in clinical practice in gynecologic oncology? This is a select list of the measures we use in clinical practice, and you'll note that the domains vary from a very general domain to more cancer-specific domains, and we have these sorts of instruments for ovary, cervical, and endometrial cancer specifically. We can look at symptoms such as fatigue or pain, emotional well-being, relationships, and decisional measures. The ones that you'll see used most frequently are here. The C30 consists of multi-item scales and single-item measures, including 5 functional scales, 3 symptom scales, single questions, that result in a global health score that reflects quality of life. The OV28 was designed for patients with local or advanced ovarian cancer and uses 7 multi-item scales assessing abdominal and GI symptoms, very relevant to our ovarian cancer patients, peripheral neuropathy, but also attitude to disease and sexual functioning, among others. So I want to end by talking about 2 studies that we've already talked a little bit about that did a really nice job of showing us practice-changing novel therapies along with associated data regarding quality of life that can really help us inform our patients. And the other thing, I said this already, but I want to say it again. If you have a randomized trial where you can compare quality of life of standard chemotherapy to your novel agent, that is really useful. That's useful information for our patients, and it allows us to have more patient-centered care. So most of you know Destiny. This is a breast cancer study, Breast-04, was a phase 3 study of TDDX versus physician's choice in breast cancer patients. A PRO was a secondary endpoint of this trial, and the quality of life data was presented at ESMO in 2022. And I just want to remind you, for those of you that don't pay a whole lot of attention to breast cancer data, this study had an amazing improvement in both PFS and OS with hazard ratios of 0.5 and 0.6 respectively. So really a practice-changing study. But they also presented a lot of really interesting data about health-related quality of life. So here you see the questionnaires that they used, the C30 again. They used a breast-specific questionnaire as well as a generic questionnaire looking at self-rated health status. And you can see at the bottom all the places where they measured PROs. It was really an intense measurement in order to collect data with every cycle for the first 3 cycles, and then every 2 cycles, end of treatment, 40-day follow-up visit, and 3-month follow-up visit. And these are the data with respect to global health score, and I'm just going to walk you through this really quickly, the graph over on the right-hand side of your slide. Worst global health score on the y-axis is vertical, going up. Better global health score is going down, which is kind of counterintuitive. The blue line is the experimental agent, and you'll note patients stayed on the experimental agent for much longer than they stayed on physician's choice chemotherapy, which is the gray line. So we have a lot more data for the experimental agent. And in this study, a 10-point change was considered, in global health score, was considered clinically meaningful. So patients were compliant with the questionnaires more than 92% of the time at baseline, and more than 80% of the time going all the way out 27 cycles, which is really important, but also testament to the fact that patients are willing to do this and feel that this is important. And I just want to make a plug for inclusivity here. We need to not only translate all of these questionnaires so that all patients can participate, but also allow patients to participate in whatever way feels comfortable to them. So for some patients, that might be a tablet. For other patients, that might be on paper. For other patients, that might be your clinical research coordinator sitting and going through the questionnaire with them. We need to be able to be flexible about that so we can collect diverse data. You'll see the mean GHS score, 36.3 with the experimental agent and 37.8 with physician's choice chemotherapy. And you'll also note that the mean change from baseline remains stable in both arms. So there really was no change in global health score in either arm, although again, we have much more data for the experimental agent. This slide shows data regarding time to definitive deterioration for both. Again, the blue is the experimental agent and the gray is chemotherapy for global health score on the left and pain symptoms on the right. And you'll note that the experimental agent did better in both of these domains, and both of these were statistically significant. There's a lot more data that I don't have time to show you that confirmed these results, and in other domains. And you'll see from this forest plot, which looks at many of these domains, that the only domain for which chemotherapy was favored was nausea and vomiting, which is interesting. But for the remainder, physical functioning, pain, emotional functioning, social functioning, et cetera, all of those favored the PRO arm. To me, this says that we have a drug that should be very successful for our patients. Not only does it improve, well, not ours, unless there are people in the audience that take care of breast cancer, but this is really important data for us to share with patients, because it says that we're going to improve your PFS and your OS, but we're also going to improve your quality of life. And this can really help us help patients in shared decision-making and making treatment decisions. I'm sure that I'm close to being over, but I just want to mention another study that did a really nice job with this, and I know that there are also going to be data coming from Mirasol with respect to quality of life. And this is Forward 1. You know, this is a phase 3 study of MIRV versus chemotherapy in ovarian cancer specifically. The PROs here are listed. We talked about the C30 and the OV28, but this also used the FOSI, which is a measure of symptom response to treatment. And you'll see the PRO analyses over on the right-hand side. And there was a focus on GI symptoms because that is important, we know, in ovarian cancer. In this study, a greater than or equal to 15-point increase in score was considered an improvement. And I'll just focus you for the purpose of brevity on the right-hand side of the slide, which shows the folate receptor alpha high population in the next series of slides that we're going to look at. And you'll note that there was an improvement in the abdominal GI symptom subscale by treatment group at week 8, much higher in the MERV arm than the investigator choice chemotherapy. Here also is shown the time to symptom worsening on the abdominal GI scale. Again, look at the right-hand side for the folate receptor alpha high population. In this group, MERV showed a nearly 2-month longer time to symptom worsening on the subscale compared to chemotherapy. There wasn't a difference in the intention to treat population. Same forest plot looking that we saw earlier in the DESTINY trial, looking at all of these different domains, neuropathy, hormonal body image, et cetera. All of these favored the MERV arms. So this is very powerful data for us to share with our patients, along with the PFS and OS survival advantages that you saw in the earlier talk. Again, categorical changes and time to symptom worsening in the folate receptor alpha high population favored the experimental agent. So in summary, these two studies and other studies that provide us with quality of life information are really critical to help us better understand novel treatments, as Dr. Moore said. However, there is the caveat that these data were collected in a very carefully selected clinical trial population. And so when counseling your own patient who may have had more than limited prior lines of therapy or who may be starting with a poor performance status, that needs to be taken into account. Nevertheless, I think this is very important critical data, and I'm hopeful that we'll start hearing a lot more about quality of life and PRO data in the future. Additionally, especially in ovarian cancer, to remind you that quality of life is predictive of mortality independent of objective disease severity measures, in large part because symptom distress results in lower health-related quality of life, particularly in ovarian cancer. And interventions like successful therapies to decrease symptoms and symptom distress will extend survival. Thank you so much for your attention.
That was great. We're right on time, so you did not go over. We broke this up a little bit because we didn't want you all, it's lunchtime, we didn't want you like sitting here listening us to sort of drone on without a break. So we built in a 10-minute sort of break right now to just address some questions on the first two presentations. If anyone had questions, please come up to the microphone and we'd love to answer them. But seeing none just yet, don't be shy. I'm just going to start us off because those were two great presentations. So I want to ask a couple, maybe a provocative question. And Dr. O'Carroll's going to bring up the enfortumab pembro data from bladder cancer, for those of you who didn't see that in her talk. So I don't want to steal her thunder, but that data was amazing. If you were in the room at ESMO, like standing ovation, kind of like the in HER2 and low, breast low, everyone's just like, whoa. It was like amazing to be there. And then we all stopped listening, after that, because like it was just sort of like, wow. And then a day later, Dr. Subaya puts up a tweet with the toxicity, which was quite high with enfortumab, and you're really asking if it's the next best thing. And I was like, well, if you're living longer, that has to be better, right? But is it? I guess so. I want to sort of ask my panel, and maybe the audience wants to speak, what's the balance of a novel new medicine that improves OS tremendously? Do you kind of figure out the toxicity on the back end, or do we really need to be more attentive to this during drug development up front? Because it's a hard question, I think. You can't feel your fingers, or you want to balance this?
One of the things that we've talked about is whether, recognizing that this is a secondary endpoint, quality of life in many of these studies, whether the quality of life data needs to be presented earlier. often we wait a long time, not always, but often we wait a long time. We get all excited, we have these wonderful new treatments to offer people, but we don't get to hear the quality of life data until months afterward. And so maybe we should be thinking about trying to present them more sequentially, or I don't have a great solution to that. Maybe you do, but I think that will help us better help our patients make good treatment decisions.
I think we have to be very clear. It's just the beginning. Right now, we have 1,500 clinical trials dedicated to ADC open for cancer patients. So what we are seeing today is the beginning of a new story, and for sure, we will improve our capability in terms of efficacy, but also in terms of safety. Now, if you want to answer directly with the current treatment, we have to be careful about the setting, because right now, if we have to compare to chemotherapy until progression, the safety profile will be compared to something for a patient receiving always a treatment. If we are moving in early stage, at the platinum-sensitive relapse or the first line, in this case, the safety profile will be clearly much more important to look at it, because the patient will not be accepted to receive toxicity for so long time. And unfortunately, also we make a great effort to explore the quality of life of the patient with cancer. Right now, our tools are not clearly really helpful to really understand if the patient have a deterioration of the quality of life, yes or not. And it is two ways where we have to work. I'm not sure we have perfectly defined a good tool to define the quality of life of the patient under treatment.
That's true. Yeah. You only get the information you ask. Yeah. You only get the information you ask for, I think, sometimes. Did you have a comment, Dr. O'Carroll?
I was just going to say exactly that. I mean, as we're developing these new drugs, we should also be developing our measures, you know, and there's no reason that because it is so important that we improve those tools alongside. I mean, we can study two things at once, and from our point of view as a physician, that's not necessarily the same as what the patient values, and just trying to think about those low-grade toxicities. I think for ovarian cancer, obviously, a lot of our patients have received prior taxane, so the neuropathy thing can be a really big deal, and trying to think of that patient population, maybe the payload is one that doesn't cause as much neuropathy. So just trying to be very conscious of what will benefit the patient and what are the type of side effects that we want to try and avoid for them, as well as obviously controlling the cancer.
Yeah, I think you made a really good point, and I see an audience in Verrier. We were just at a meeting yesterday, in fact, and I'm not saying anything about what we just presented, but we always do this. We're like, oh, here are the toxicities, and the majority were grade 1, 2. Like, I say this all the time. Okay, well, grade 1, 2 alopecia may be one thing, but grade 1, 2 neuropathy, if it's mostly grade 2 neuropathy, is a much different sort of toxicity from a patient standpoint. And we don't tend to prioritize things until they're grade 3 or higher. Like, that gets the black box, but maybe other things should. Yeah. I'm going to go to our audience member, please.
Yeah, a basic question, because I'm a surgeon. I'm a professor at the All India Institute of Medical Sciences, Rishikesh, India. And we have less opportunity to use immunotherapies and ADCs. I'd like to know what's the toxicity profile between ADCs and immunotherapy, right? And some basic questions, basically. What do you mean by payload? Yeah, these are the two questions. The toxicity profile, ADC, difference between immunotherapy and ADCs.
Got it.
And, yeah.
And and what we mean by payload.
What is payload?
Yep.
Payload is the easy way. Currently it's a cytotoxic drug. It's the part of your antibody who will be able to induce your cancer cell death, in general via apoptosis. And so we currently use cytotoxic, but also right now we are more and more exploring other drugs. I speak a little bit about the STING agonist, but there is several compounds who can be considered as a payload for the future and to be able to induce this cancer cell death. So right now the payload is the killer of your cell. Considering the safety, we have several data now to consider antibody drug conjugate and immune therapy, both in combination. I'm thinking that you will mention that. And the safety profile is not so bad right now.
Okay.
But we also consider now two different payloads on the same antibody. We can be able to manage the resistance to treatment. So I think the technology is really improving. I hope I understand the question.
Yep. Did we answer your question?
Partially, yeah.
Okay.
Maybe.
Hi, Yvonne Lin from San Francisco. I think this is a really fascinating discussion about the quality of life and sort of the patient perspective. And I think actually this provides a really ripe opportunity to reinforce the need to incorporate the patient opinion earlier on in the drug development process. And this can be in the form of patient advocates or survivors on steering committees, reviews, et cetera. And this is a priority in the US, and so I think this is a great opportunity to kind of reinforce that.
Thank you for that comment. I absolutely agree with you. We need to involve them very early in the process.
So I just want to add, we of course met about this ahead, and there were a million things we wanted to put in the slides that we couldn't. But we just wanted to bring up, I wanted to bring up just a little bit of a discussion around ILD, because it's not a common toxicity, so it didn't make like the common toxicity list, but it's a very important toxicity. So I wondered if the panel could maybe just give a brief, with a minute and 40 seconds, sort of overview on ADCs and ILD.
I will briefly touch that in my talk, but I think it's important that we, traditionally say we're thinking about MEK inhibitors or TKIs, we think about class effects, we think about certain toxicities that we expect to see. However, with ADCs, it's really important that we actually think about the antibody, the payload, those really, and definitely the target antigen. So just because we see, so there might be a particular ADC that's associated with an extremely high risk of pneumonitis, but then you might target the same target antigen with a different ADC and you see minimal. And so I think a lot of it will be dependent on the actual payload and also the monoclonal antibody. And so once we get a good target, I think then we'll be able to figure out strategies to reduce the risk of pneumonitis. But as clinicians, as we move into using these drugs, it's so important that we're aware of these drugs. And just because I've experience with tisotumab does not mean if I start using sacituzumab that I expect the same toxicities. Certain ones, for example, in the bladder world, they have a significant rash, and it's really important that patients are immediately held, and that there's a big steep learning curve with these drugs. And so I think that's something that we just all recognize how steep that learning curve is, and that we educate our teams as we bring more and more of these agents into the clinic.
Yep, agree. Thank you for that. Well, I think we'll move to your final presentation. So without, oh wait, we have a question and then we'll move. Yes, please. Please ask a question. I can't quite hear you though. Maybe, there you go. We're good. I can hear you.
Yeah, hi. Okay, I think some great slides on survival improvement and quality of life improvement, but I'm bearing in mind it's IGCS and a lot of people here from low middle income countries. We need to hear a bit more about cost effectiveness as well.
Yeah.
Because I suspect a lot of these drugs are going to cost a lot of money.
They do. They cross, yes. That's what goes without saying. Absolutely. That's like a symposium in and of itself. And you're absolutely right. We are at IGCS, where we have a lot of colleagues here working hard to take care of patients in low and middle income countries where we're not even getting sort of our most basic therapies to them, much less an expensive antibody drug conjugate, and then all the QOL tools. So your point is spot on and very well taken. I think it's just going to take continued, a lot of those countries don't even have the infrastructure we can bring trials in there, which we're talking about on the international level now. You'll be happy to hear very high level discussions about trying to bring trial infrastructure to a certain continent that has almost no oncology trials right now.
Yeah.
I think we can all guess which one that is. But until we bring trials into those places and then the manufacturing capability, getting these drugs there is going to be
I'm from
difficult.
the UK, and we've got NICE who will do cost effectiveness analysis before they approve it for use in the NHS, for instance.
Yeah. That is an excellent point. I don't know that I have any more. I wish I had something brilliant to say, but I don't.
Okay.
Drugs are really expensive. Too much. Okay. Next, Dr. O'Carroll is going to bring us home with a fantastic presentation on the future of antibody-drug conjugates. Dr. O'Carroll, thank
Got
you.
our slide.
Yeah, that one can go. Yeah, there we go.
Thanks so much. So, I mean, initially, there's been such a long history. It's ADCs, you know, are a very topical thing now, but these drugs have gone way back in the development. Initially, ADCs were developed as tumor-specific murine monoclonal antibodies that were covalently linked to drugs, anti-cancer drugs such as doxorubicin, vinblastine, and methotrexate. However, in these early studies, what we saw was a much limited efficacy because of the development of immunogenicity, lack of potency, lack of specificity, and really since that time, a lot of lessons have been learned. The murine monoclonal antibodies have been replaced with humanized or fully human monoclonal antibodies. Potency has been improved. We now have a lot more potent payloads. Selectivity has been extremely important, both being more precise in the target and also our antibody selection. In 2000, gemtuzumab was the first ADC in cancer that was granted accelerated FDA approval for AML. But since that time, we currently now have 13 anti-cancer FDA-approved antibody-drug conjugates, and 2 of these are for patients with gynecologic cancer, mirvetuximab soravtansine and tisotumab vedotin. I think over time we have learned a lot of lessons, but there are so many more to learn. And it is extremely important that even from our apparently negative studies that we continue to learn, and that as we move forward that we develop more effective treatments. So UpRi, or upafitamab vedotin, is a great example of a novel ADC that was looking at a different target antigen. In this case, it was sodium-dependent phosphate transporter 2b. It had it was through a linker. It was attached to a novel payload, an antitubulin one. And what we learned here is that although we saw, we didn't see the results that we expected, there are various, when you go through the development of this monoclonal antibody and ADC, I think we can see how important it is that we learn lessons and continue to evolve. One of the things that we had seen initially in the preclinical studies, that it seemed that target selection was, the target antigen expression was particularly important. And so as they moved forward, they looked at the biomarker-rich population. It does depend, though, on your antibody-drug conjugate, and you can't just assume that rich target expression is required. It really is a case in point, and then paradoxically, in some cases, target antigen, the degree of target antigen expression has not been shown to be a predictive marker. Also, it is very important that we understand the dependency of the cancer on target inhibition and the sensitivity of our tumor cells to the particular ADC warheads that we're using. We also can't forget that there are some kind of, as we just discussed, class effects. So there are some with certain payloads we expect to see pneumonitis, but there can be a very steep learning curve with these agents. And in fact, in the case of UpRi, bleeding, although it failed to meet its study endpoint with only a response rate of 16% in the biomarker-rich population and 13% in the overall population. We saw the expected pneumonitis, but in this case, and often it's not become apparent until you do the larger study, there was unexpected fatal bleeding events that were observed. So here are some of the main ADCs that are currently in development for ovarian cancer. They vary by the target, the linker, and the payload. And these are really, some of these have been associated with extremely impressive objective response rates. Dr. Moore just presented 2 weeks ago an objective response rate of over 50% with the Cadherin 6 ADC. So let's start. How can we improve our antibody-drug conjugates? Well, we can start with the antibody. So it's extremely important that we have high specificity between the antibody and the antigen. We also want high affinity between the antibody and the antigen. It must be able to actually reach its target, and that high affinity will allow the uptake and the internalization to allow the antibody-drug conjugate to actually to be able to be efficacious and induce its cytotoxic event. Sometimes we might actually be able to target what was previously thought to be untargetable or undruggable targets with new cleave with new masked antibodies. So basically, the antibody is only expressed when there are the presence of certain proteases in the tumor microenvironment. As we think about the studies, unfortunately, we frequently see development of drug resistance and antibody drug, and so it's equally important that we continue to learn. And for those patients undergoing treatment, those post-progression biopsies are very, very important so that we can better understand the mechanisms of resistance. Taking from other other solid tumors, for example, with sacituzumab, they have learned that they are acquired of certain SNPs that can lead to development of resistance to the particular antibody-drug conjugate. And again, it depends how important we think that that tumor antigen is in the first place for the efficacy of the particular ADC. There are other PK properties of the ADC that are extremely important. So we know, for example, that the properties of the antibody structure itself, how lipophilic it is, the size of the structure. Our bioinformatics colleagues have done amazing work at trying to really improve the actual structure of the agents themselves. We know, for example, that for agents, the serum half-life, the ability of it to traffic to the tumor, and also the importance of the antibody in perhaps being able to instigate and overcome the hostile tumor microenvironment are extremely important. The linker itself, well, we can think, the idea behind the linker is that it's there to try and prevent the drug being released prematurely into the circulation. And so it's the idea is that once it gets to the site that we want the drug to work at, that it's actually, it's at that point that the drug is cleaved off. However, again, we can vary our linkers depending on where we expect to encounter the target antigen. The conjugation site is also important. So for where the payload is attached to the actual monoclonal antibody, there are some really novel approaches. Usually you're committed to only a drug-antibody ratio of 3 to 4 with conventional ADCs. However, there are very smart ways where they're at a single conjugation site, you might be able to, in fact, deliver several payloads at that single conjugation site. And a lot of work has been gone into trying to develop optimal modeling for these monoclonal antibodies. Another thing that's so important is optimization of the therapeutic index through targeting and design by achieving a balance between an efficacious dose and the intolerable dose. The therapeutic index is a quantitative measure of the relative safety of the drug, and here we can see a small molecule chemotherapy which is on your right with a very narrow therapeutic index. However, as we develop ADCs, some of these allow a much higher dose of the drug to be delivered because of a much broader therapeutic index. The drug to antibody ratio that I mentioned, so that's the average number of the drugs that are conjugated to that individual antibody. That we know that over time, so as you increase up the DAR, the drug to antibody ratio, that's great in terms of potency, but the problem is then you're substantially reducing the half-life of your ADC, and it may even not manage to get to its potential target. So increasing the DAR may paradoxically actually reduce the efficacy of your drug. Trying to deliver the drug at its site is extremely important, and trying to make sure that it actually can be efficacious. Another thing that we look at is the heterogeneous and low tumor expression of a target ADC. So not every single tumor target has to be highly expressed. It really does depend on the ADC, and we've seen that time and time again. In the HER2, we've seen great results in terms of those patients with tumor antigen low, so in this case HER2 low, and in fact it does greatly depend on the actual antibody drug conjugate that you're exploring. Unfortunately, in the case of ovarian cancer, it tends to be quite a heterogeneous tumor. And it's difficult to know, again, depending on how important presence of the target antigen is, it's difficult to know when exactly should we time our assessment of the presence of the target. Is archival tissue sufficient? Should we be doing these kind of assays in real time? Do we expect that antigen expression to change over time? And in fact, in particular tumors, we don't even necessarily see uniform expression depending on the histologic subtype. And we can't just assume that because of expression or activity in one tumor type that will replicate to success in another. Again, in ovarian cancer, within the same patient, we often see significant antigen tumor heterogeneity, and this may be very important and that we look very closely at this as we're trying to better understand mechanisms of resistance. And this heterogeneity really is a huge challenge, and this may be very important, particularly in ovarian cancer, that we have dual targeted approach and that we're not just relying on a single ADC. There has been a huge explosion of potential targets that we can look at, and it's very important when we're developing these, not just to continually target the same targets, but to try our best to look at those novel targets of expression. And so I think equally important is, as we see with conventional chemotherapy, patients often develop platinum or taxane resistance. We also have to be very mindful of this when we're developing our payloads, and not to just, so the importance of delivering different types of payloads, I think, will be increasingly important as we try to sequence these antibody-drug conjugates. Equally important, though, is to remember that tumors are not just comprised of cancer cells. There are so many other really important cells present in the tumors that aren't necessarily malignant cells, but that are able to foster that hostile tumor microenvironment. And so we have seen great strides in developing novel ADCs that potentially could target anti-apoptotic pathways, or perhaps even target those regulatory T cells that often hinder our ability to develop effective cytotoxic treatments. We talked a little bit about the bystander effects, and this can be really important, and another thing that is very important that we consider when we're thinking about our particular ADC. So for those ADCs that have a very potent payload, you may actually want to substantially limit the bystander effect. However, for those with maybe a less potent drug, you may want to promote diffusion of the ADC payload into the neighboring cells. So trying to think those things through and being very mindful of these as we design our agents. Again, obviously the increased bystander effect, as Dr. Duska stated, it definitely substantially increases the chance of off-tumor toxicity as well. So trying to be mindful of those as we move forward. Another thing that we have to think about is whether or not we should be considering using ADCs earlier in the disease course. We saw with mirvetuximab that patients who were less heavily pretreated, in fact, we saw that patients who were less heavily pretreated may have derived more benefit. And as we move forward with these agents, it's possible that we'll try and move them further and further in the upfront setting. It's a very fast-moving landscape. It's next to impossible to keep these type of slides up to date. It's just an ever-evolving field. But what I think will be moving forward, I think what we're going to be looking at is combination therapies, be it with immunotherapy, be it with dual targeting of antibody-drug conjugates, or be it with other novel agents. We saw amazing, this is the results that Dr. Moore was alluding to, that was presented by Dr. Powles at ESMO this year. And in this study, it was for patients with this is first-line management of bladder cancer, and they gave the ADC that's known to be quite active in the enfortumab in the recurrent setting. They combined it with pembrolizumab, and they showed a hazard ratio of 0.47 compared to conventional chemotherapy. So phenomenal results there. And one of the attractive things about these type of agents is often, in particular with the ADCs that we use in ovarian cancer, we expect that they won't necessarily have a lot of overlapping toxicity. So that's really a great avenue, and it would be so amazing if we could move these type of agents into the upfront setting, and maybe even for our patients having a non-chemotherapy option in the future. I think the future treatment landscape is bright. We have so many potential combinations. And so I think it'll be just very important that we're mindful of how best to develop these. We already heard from Dr. Kurt that there's, what did you say, 1,500 studies with antibody-drug conjugates, and it'll only get more complicated as we move into the combinational approaches. I do think, however, combinations will be a key in order to reduce the incidence of development of resistance to these treatments. but I think it'll be equally important that we're very mindful and careful and not just add agents because we can, but very mindful about the potential for synergisms and having a rationale, especially to the point of financial toxicity, not just using all these very expensive agents at once, but being very careful in selection of the patients who are most likely to derive benefit. And also perhaps equally important, and something I didn't even touch on, is identifying markers of patients who are most likely to develop toxicity from a particular antibody-drug conjugate. And there is a lot of work underway in terms of that, more so in the other solid tumors, but I think there's a lot, it's a very busy landscape and a lot of lessons that we can learn. I think this is you.
So I'm just going to moderate from here. So thank you so much, Dr. O'Carroll, for that excellent talk. I changed my mind, I'll come up here. So just to summarize a little bit of what we've heard about, and then we're going to open it up for questions. We have about a little less than 15 minutes, so we can actually get some good discussion going. But what we really talked about today is there's a lot happening in GYN. We just really covered a lot of the ovarian cancer landscape, but the ADC discovery in endometrial and even cervix is really rising and just as robust. So it's an exciting time for those of us that take care of women with gynecologic cancers. There's just a lot being to look at that's being explored as monotherapy as well as combinations, as you just heard. There we go. There's a lot of work, and this is one of the things I want to have our group discuss a little bit, is the diversification of antibody-drug conjugates, not just with payload, but with targets, with linkers, and how we really think about this strategically as we're developing multiple antibody-drug conjugates, sometimes in the same space, which is okay, but how do we diversify those right up front so we make sure we understand how we're going to sequence these agents and use them in the next phase, I think is really kind of staring us in the face right now, and we'll talk about that. We think that ADCs are targeted, and they mostly are. They're targeted chemotherapy. So we see toxicities, as you can see here, and we've mentioned peripheral neuropathy, pneumonitis, uncommon, but there. Eye toxicities, a little bit of heme toxicity and GI toxicity. So even though they're targeted chemotherapy, I present these to patients, it's like a Trojan horse sneaking the cancer or the chemo in the cancer cell. Some of it gets out, and so we do have collateral damage that needs to still remain front of mind. And so these are kind of the key considerations and things we want to talk about a little bit as a group and with you. And Dr. O'Carroll brought this up. How do we screen patients when biomarker is important? Some of our agents, biomarkers not important, tisotumab vedotin and cervix. We don't have to test the biomarker. Others, it's critically important, like folate receptor alpha and mirvetuximab, very different scenarios. How do we best assess that for our patients? Is it archival tissue, or do we need an upfront biopsy? Is there any way we can move this to liquid biopsies? You already heard, should we be moving antibody-drug conjugates earlier in the treatment lineup for patients with malignancies? And then really, how do we think about companion diagnostic development, these biopsy assays, better incorporation of quality of life and PROs, as we discussed, better tools, and more involvement of our patient advocates. So those are the things we want to talk about in the next few minutes as a discussion. So please come up and chat with us. But I'm just going to sort of throw it out to my colleagues. And many of you do take care of breast cancer, and so I think you actually are a little ahead of us in thinking about this. But to any of my colleagues, we learn a lot from breast. So breast has trastuzumab deruxtecan in HER2 low, and they have sacituzumab in HER2 low. And so they have two different targets, similar but not the exact same payload. We're going to be in the same situation. TROP2 is moving into GYN, HER2 ADC is moving into GYN. How are we going to figure out how we sequence these medicines? What's driving resistance, and does that matter in terms of how you sequence it? How are we going to develop these in a rational way so our patients can be best served by what's going to be a panoply of agents role?
I mean, I think one of the, say the HER2 example, it's well-defined in gastric cancer, it's well-defined in breast. We haven't even well-defined what we mean by HER2 expression for our gynecologic cancers. That's definitely something that we need to focus on. And then something I didn't mention is often we say HER2 zero, so we think it's not expressed at all. However, when you do immunofluorescence, you can actually see the presence. So thinking about it historically, most of our assays were developed to look at high expression. That's the whole rationale where they were developed. So they're not necessarily serving the same purpose. We weren't looking for any expression. So I think we will have to refine our companion diagnostics if we're looking at these agents that may be particularly active in any type of expression. So I think we're at a bit on the back foot because we just don't even have those. And we often talk about HER2, for example, but are we talking about mutated, amplified, even those basic things we still have to, I think, work on. And then we'll have all these different choices, and you're totally right. Like, will it be, I think if you have high expression, maybe you don't want as potent an ADC. We're definitely in the lower, you need a more potent one that will be able to exert some kind of efficacy. But I think all those things, and then the individual patient, what type of toxicity would that patient be able to tolerate? Is there a concern if they've already received IO that we're worried about exacerbating pneumonitis? As Katie and I are developing cell therapies, often when we're giving new cell therapies, we have to take into account that they may have received these type of agents and perhaps had pneumonitis previously. So it's become a lot more complicated to know how best to treat the individual patients.
Yeah, comments, keep going.
For sure, it's one of the most important questions right now, and I'm pretty sure that all our colleagues from pharma company who are in the room will be very interested to have the right answer. We don't know exactly. What we can do is, as usual, to be pragmatic, because we know that right now the compound will not be explored directly one against the other. So in general, the data we will have is compared to the standard of care. And in this case, what we will do indirect comparison for sure. We will also look at the efficacy and the safety profile, looking to the setting, because probably the resistant population is completely different than the first line. My point is about the biomarker. I agree with you, Rosine. A whole broad population will be not probably the future. For several reasons, and the cost is one of them, but also the safety for the patient. And starting to understand will be our capability to be better for the future. If we continue to explore in all comers, it will be fine, but we need to be sure we will be able to address the question by biomarker. And the biomarker right now is not so strong in terms of feasibility. We remember the forward experience, but we know also that the antigen expression on the membrane level can vary a lot during the disease. So using archival tissue is probably something much more complex than using fresh tissue. Probably the liquid biopsy and signature using RNA-seq for such kind of treatment will be the future, because it's easy for the patient and also for us. And this needs to be systematically included in all the clinical trials we are designing right now. It's a very vague answer, I agree, but in the reality, what we need to put in the trial to be sure to have the answer next year or the year after is probably the best response we can say.
Yeah. I still don't see any questions, but feel free to come up. So another
Katie,
thing-
wait, I'm sorry, can I
yeah.
add something to that?
Absolutely.
I agree with everything that everybody said, and I just want to bring up the issue that somebody in the audience brought up earlier. We need to think about cost. We need to be cost conscious, and these drugs are expensive. And even in the US, I'm not sure that we can afford all of this either. And so I think we need to more work on cost effectiveness for these agents and really think about when making decisions for patients about cost.
Dr. Eskander.
Thank you, first of all, for an excellent set of presentations. I always learn so much. To that point, as we develop these trials and identify that we are taking a population of patients and reducing it because of biomarkers potentially, so we're having an external pressure, sometimes institutionally for trials, to accrue sufficient patients, but we're being driven to open trials where there are fewer and fewer patients that are eligible. But then in parallel, making sure that all of the other institutions who are not doing trials are testing so they even know to send patients for enrollment on trials that are biomarker specific. How, collective perspective, both US, ex-US, globally, how are we going to message that so that we can ensure that we can, one, operationally conduct these studies in a timely manner, but get these therapies to the patients who might benefit the most from them?
I can say more. No, there is something that we need to remember is the patient need to decide. And unfortunately, I have seen several times the issue that when we ask for the tumor block to have any prospective biomarker analysis, sometimes the pathologist did not send the block. And this is something that I would like to emphasize because we need to remember that it is the patient life and the patient decision, and we are just there to try to help and to try to direct the treatment, but not to decide so much.
I think you bring up, though, I mean, it's a little bit unanswerable in this setting, but we're all thinking about it. Dr. O'Carroll and I are doing cell therapy for HLA restricted and a MAGE-A4 restricted. So everyone has to be tested and then tested again, and then they can come in to maybe participate in a trial. It's a niche. You and I were at an advisory board at ESMO for a drug that could be landmark, that's going to be 4% of the population, but maybe could be curative in the front line. Some of these antibody drug conjugates are targeting a receptor that's maybe widely there, but high in 30%. Maybe it's another mirvetuximab. So the design of these studies, and we keep trying to fit our studies into these cookie cutter, things, high unmet need, all the things that have been kind of successful in the past. But if we're really going to make big movements for people, it's going to come in these smaller studies. But how we do it globally is a big challenge. And I don't have a great answer for you other than I think we are really smart and we can be innovative. But these big studies are probably going to be a thing of the past. I mean, I think it's going to be really niche, just-in-time study activations. But you have to have access to testing, which is the challenge even in the US. Majority of our patients don't get access, much less ex-US. So you asked the right question. I don't think we have the answers. And on that sad note.
I have a question for you, Cathy. One of the most things we have seen with all these EDC is the response rate, who in general is higher than when we explore immune therapy and so on. That means that perhaps we can bring the drug immediately in the neoadjuvant setting or in the windows of opportunity clinical trial before to receive any local treatment, where we have the possibility to learn quickly and deeply about the impact of the drug on the tumor, but also on the immune response, that I think is something important also with EDC. Do you think that the scientific world is ready to start to explore EDC in the neoadjuvant setting just before to receive surgery or radiotherapy?
I mean, I think we're all ready. I think our patients are ready for it. And the studies that we're doing now, and I'll just call out the obvious, Destiny Pan-Tumor, and we saw some updated data on that at ESMO. It's still only 40 patients a cohort. I would like to see some more patients. But if you're an 80% expected response rate with a 3+ endometrial, okay, why do I need chemo? And I think patients are ready for that. And I think the same thing is true in cervix, which is a much smaller population, and that is going to be a really hard study to do, but somehow we need to figure it out. Ovary with carboplatin, I have to say it's a little bit of a different ballgame. I don't know, what do you think, Roisin?
Yeah, no, I totally agree. But I mean, with those kind of, if we see those response rates, that's what we see. Is it ethical not to move those things earlier in the disease course? Yeah, so I think, I hope in the future our first-line therapy will be non-chemotherapy options, and that we will have, it'll probably not be a single ADC, it'll probably be, maybe it will be an ADC, but it'll be combination approach. I think the fortunate thing in ovarian cancer is there tends to be a lot of tissue, unfortunately. That's, for the individual patients. In cervical cancer, we may not have the same kind of access. And to Remeza's point, you may end up, using up your tissue and not even have those opportunities. So I think it's very important. We're thinking of financial toxicity, but also maybe tissue toxicity and using it up. And so.
Yeah. Hey. Hi, Dr. Manish.
A philosophical question. Some of us have spent the last 10 years looking at genomic biomarkers in ovarian cancer, and I noticed you haven't mentioned the cancer genome at any point. We know that response to DNA damaging agents varies massively depending on the biology of the cancer. So how are you going to layer that into your ADCs?
Yeah, there was an interesting study with sacituzumab and one of the PARP inhibitors. In that case, it was rucaparib. And there was a really great, strong scientific rationale, exactly, and particularly in ovarian cancer, why you would combine the two. And I mean, we always think of everything as immunotherapy. If it elicits cell death, it's immunotherapy. So there's a very strong rationale for why we would move those forward. In that particular study, it was limited by a lot of myelosuppression. But I think all we have to do is just become a bit more clever in looking at the combinations and trying to make sure that we don't have overlapping toxicity. So you're totally right. And I did have a slide. I must have forgotten to put it in, looking at that.
And also, Rosine, it is because right now the majority of EDC include tubulin inhibitor and not DNA damage. That's, I think with Topo 1 and DNA, we will see much more information with the genomic profile.
All right, well, with that, we have 10 seconds left, and so I will bring us home. I just wanted to say this concludes our symposium. Thank you to our presenters today, and especially thank you to the audience for asking great questions. This session will be available as part of the IGCS On Demand program following the meeting. And the GOG Foundation and GOG Partners would again like to thank Immunogen, Mersana, and Novacure for their support of this program. Have a great afternoon, and we'll see you at the rest of IGCS. Thank you.